Oh,
Sorry for the delay.
that's okay.
Lots of action in my space, but here we are, and good morning.
Well, here we are, and good morning. And it's been forever and a day that I've talked to you and everybody else. So, welcome. I have to take a deep breath. You made me nervous.
Sorry.
That's
So sorry.
okay.
Yeah.
It's my job to worry. Thank you so much
I
for that.
apologize. I apologize, Carolyn and everybody.
No, it's fine, really. So, anyway, as is per usual, welcome Dr. Rosensweet, Dr. David Rosensweet, dear Dr. David Rosensweet, and to everybody who's going to be coming in. Hope the holidays were really nice for everybody, and we'll get started.
All right.
All right. Okay, so this is anyway, question comes in about thyroid. Is it a likely time for a thyroid nodule to appear at the time of menopause? I am convinced this is a part of my menopause problem, but I've been to so many doctors and none of them agree with me. I'm having a wicked menopause, have had 2 FNA biopsies, but without any results. But they want to take my thyroid out anyway, just in case I have, this cancerous nodule. But I'm not on board with that. Wondering if Dr. R has ever experienced thyroid nodules appearing at the time of menopause. So she's confused. I'm confused. I can't answer that for sure. But I'm going to give you a shot. I bet you can.
I haven't. I've definitely run across thyroid nodules, and there's a couple questions embedded in this question. One of them is a raucous menopause.
Yeah.
And that always calls for the exact same thing. The drumbeat is, you have a job to do, patient. It's find a healthcare provider who's specializing or knowledgeable or experienced or trained in treating women in menopause with compounded bioidentical hormones. Go shopping, find that person. It's very important. Raucous menopause, I always thought, from my perspective, that a raucous menopause was, oh, now hear this, the ideal thing for a woman in menopause. And 75% of women have just really life-challenging symptoms, like can't sleep or mood tanking or can't think clearly, et cetera, et cetera, et cetera. Now, when women are having this experience, and 75% of women do have this, they have really life-challenging symptoms. I've always considered this to be the very best thing that can happen to you, because the interference with your life is so severe that you go out and seek a solution. And the solution you need to seek is you go shopping, do your research, talk around, find a healthcare provider who's treating women in menopause with compounded bioidentical hormones, who knows what they're doing. They're out there. Contact us at the Menopause Method. There's some states where we can really assist you. Why would I make such a crazy comment like this is the best way that can happen to a woman? The women I'm really concerned about is the women, they have very few, if any, symptoms in menopause, or they have a few hot flashes, or they have a couple months of symptoms, and then the symptoms stop and they feel like I'm through menopause, or my menopause was easy. These are the women that I am absolutely most concerned with, because they still have low hormone levels. They still have loss of bone and muscle, almost a guarantee. It's not like maybe this is going to happen.
Right.
They have threat to their arteries and bladder and vagina and libido and energy, on and on and on, because we need these hormones. These are our powerful power chemicals. And when we lose them, there's very significant losses that take place, and they almost always take place without exception and you don't feel it right away. But I can tell you, and Carolyn, you and I have really resonated with this very strongly. A woman's life is going to mean as much to her in her 80s and her 90s as it does to you right now. Your life is going to matter, women out there, when you're 80 and 90. And these changes that take place, these loss of muscle and loss of bone that occur from low ovarian hormone levels, and loss of cognition, and loss of libido, and loss of vagina, these are almost sure things.
I'm sorry to interrupt. I wanted to ask, these symptoms occur, but a lot of times thyroid is involved in this.
Well, I'm going to thyroid. I promised to get there. I know there was two parts to that question. She was having a challenging menopause, and that's not related to the thyroid. And I'll get to that. Thank you. I love how you keep me on track. But I was going to go there. But I wanted to deal with one of the most important things, and the one where our expertise is. And so that's why I want to address that first. And I've told this story many times in this Facebook Live of I'm a senior medical student. We're working in the hospitals.
Oh no! Don't freeze on me.
Lectures by various experts, and we get a lecture from a gerontologist, and I'm 28. And what do I want to hear from about old people? I'm 28. Medical student. But my God, did this gerontologist capture my attention? He said, here we are, you're senior medical students. You know thousands of diagnoses. Let me tell you what's happening to old people. They're losing their muscles and bones, and they can't walk or stand with stability, and they fall on their osteoporotic hips, they fracture a hip, and they die. So if you want to do something for older people, this is what you need to address.
And of course, he didn't tell you how.
But they didn't know that much back then.
Yeah.
And we do now. We do now know why women lose bone and why they lose muscle. And it's loss of your ovarian hormones. Or the flip side of this is you replenish those ovarian hormones and you don't have to have those losses. Right. That's how rocket surgery it is. Replenish the ovarian hormones and you don't have to have those losses. As I said many times, I have a 79-year-old patient who's still having intercourse, playing golf. Her goal for this year was, I'd like to get 10 more yards in my drive. 79. Been treating for her for 20 years. I'm saying this to you because the menopause issue is addressable by people who are specializing in menopause. Let's go to the thyroid. Thyroid issues are extremely common. They're midlife, and the thyroid hormones are very powerful and very deep, and they help animate metabolism, for example, among many other things. But they can participate in the fight or flight response. And people who are jacking, all of us have got our pedal to the metal for the fight or flight response, usually from a very young age. So what happens in midlife? We get low thyroid hormones amongst low adrenal hormones, amongst low ovarian and testicular hormones.
To name a few.
They're all recruitable for the fight or flight biology. So, right. Functional hypothyroidism, that means your blood tests are, quote, normal, but you don't have enough thyroid hormone. So thyroid issues are very common, but that's not the question you asked me. What about a thyroid nodule? There are physicians who specialize in thyroid nodules, and I totally defer to them. And they're doing fine needle aspirations on this thyroid nodule. And to me, it's critical. If they discover thyroid cancer and it's clear cut that you have it, I'm going to give you my best shot. Let them do what they want to do. They got powerful tools. And this is a great thing about thyroid cancer, is distinct from several other cancers, is it's identifiable and treatable at early stages. And to me, it would be just very, very sad. Yeah, who wants to go in for an operation? Or who wants to have radioactive iodine injected into their body to knock out their thyroid gland? Oh, yeah. Can I have some of that? Not.
Not.
But, living on Earth has got a lot of challenges, and we do have some things that we've got some things that we can actually remedy. And I know people have developed an aversion to modern medicine for a lot of reasons. I did in 1968 when I left medical school. I love medical school. It was like a synagogue for me. At the same time, a lot of things that were being done were of concern to me. And the influence of adverse forces, the fact what's happened to the medicine I know and love and have always loved and love now, it's taken body blows that are so severe. And there's so there are things that are questionable. However, there are great things. And I'm part of the tribe called healthcare providers. And we range from janitors in hospitals to neurosurgeons and everyone in between and social workers. And oh my God, there's an army of people in the health caring world. And there's a lot of beautiful, devoted, I get tears right now thinking of those who are putting their lives on the line. So you're not going to find me lean in the department of criticizing modern medicine. I'm grateful, and I've had some procedures myself from highly skilled, trained people. I'm so grateful for it. So don't throw out the baby with the bathwater because there's some bad eggs. There's bad eggs in every profession that you can name.
Oh,
and there's good eggs. There's people who care and have great integrity. And
they're very identifiable.
if you got a thyroid if they've done a fine needle biopsy and they see a cancer in there, I'm going to give you my best shot. Just say yes. And no, are you going to love it? You're going to be grateful for it. Save your life. Your life's on the line if you've got a thyroid cancer. They're so treatable when they're found that you don't hear a lot about people dying of thyroid cancer.
Does estrogen contribute to like?
I think cancer is really, by many people, not really understood. And I look at it entirely different. There are many things that contribute to the health of our body and sustaining health, and they really matter. And they boil down to issues of nutrition, toxic exposure, exercise, too much or too little. And the elephant in most people's room is the deleterious effects of having a dysfunctional response to stress. It's not the stress. It's having a dysfunctional response and not doing the great work of becoming responsible for, conscious of, and acquire the information, tools, and support to deal with the emotional pain and the distorted thinking, dysfunctional thinking that's not true, and deal with it and work it. And this is the great work. And it's incumbent upon every human being to do this work.
It's really well
and then
put.
There's mysterious causes. But the cause of something so significant as cancer is not estrogen, for God's sake.
It's a question that came in.
I know.
Gotta ask it.
It's not about hormones. Cancer is caused by very significant transgressions, and a lot of them that took place over the course of your whole life. And then there's the mysterious reasons that we can't exactly name, but it's
Right.
there. And if they found one, do what it takes. Commitment. I think some people really understand the word commitment, and other people don't understand the word commitment. And commitment is you do what it takes to do the job that you need to get done. And if you've got a thyroid cancer, you've got a job to do. And so I say, go out and do it. And I'm so, it's so disturbing to me to see the radical, judgmental division that's taken place in the United States now in the world of healthcare. Masks or no masks. Give me a break. Vaccine or no vaccine. It's like, if you don't do the right thing according to your value system, the other people are the devil themselves, Satan themselves. It's not true. We're all humans, and yes, each individual needs to make a decision that's based on their own viewpoint and then what their effect is on others. And so I've gone a little far afield here. Very unlike me to do that. Wouldn't you say, Carolyn? I never do that, really.
I've never known you to do that. Yeah, but I'm unconscious most of the time, so I'm
That's
just
not true
kidding.
either. That's not
No,
true
not
either.
at
You're a very caring,
all.
committed woman and human being. You're,
Thank you.
yeah.
Thank you. I am, and yet everything that comes out of your mouth is always so good that it's almost hard to stay on track. So I'll go to. I have questions here from Levon and from Levon. I'll get to those in a second, Levon. Let me get to the second question, which is I've had a very challenging time with HRT, breakthrough bleeding. Since April 2021, 8 years post-meno, on hormones since 2020. 7 millimeter thickening, I believe, millimeter thickening of uterine lining, progesterone level 18. She's taking 400 milligrams Q12 every 12 hours. And her estradiol via blood is 80. So she's wondering, why the heck would I still be experiencing breakthrough bleeding? I thought that progesterone would be protective, but it seems not to be, and I'm confused.
Yeah.
I mean,
I
400
would
is
say confusion is one word that could be used, and this is a common situation, what this questioner is asking. I'd say there's other words that could be used to describe your situation. It's the knowledge and experience it takes to do a good job with hormones is rather staggering.
yeah,
It's like anything else, and I've told this story many times. I had this desire to rebuild my Corvair engine. I had a Corvair van, and I did.
right.
While I was an intern, no less. And I had the manual, and it was fun. Oh God, it was so much fun to take that engine down to zero. I used to like erector sets when I was a kid, and it was so much fun to take that engine totally apart and do what you need to do to rebuild an engine. And I put it back together, and that thing ran. That Corvair van ran. We traveled from Ann Arbor to Santa Fe in it. And that's as far as we traveled, because at the 7,000 mile mark, it ground to a total halt. It froze. And gee, I had followed the book. And then I had a Volkswagen van a couple of years later, and I needed an engine rebuild. And this time I took it to a Volkswagen mechanic who rebuilt engines. And he was so kind. I was so interested that he let me watch him in the 2-day process it took him to rebuild this in New Mexico. And I was just marveling at how many steps he did and how much he knew. And by the end of those 2 days, I said, I know why my engine froze. I didn't do all those things.
Oops.
And this guy had rebuilt over 100 Volkswagen engines.
Right.
And you're floating in a world, menopausal woman, where there's a lot of moving parts. We have this wonderful compounding pharmacist who actually advises physicians on how to prescribe to women in menopause. And she sees 5 patients a day, 5 days a week, and she's done so for many years. and she's also done our training, and she's a star in our program because she's so knowledgeable and experienced. And one day recently, in the last month, I asked her, Mary Lee, how many women do you think are totally typical in menopause that are just boilerplate? You just do it and they're done. And she said, "Oh, let me think. How about 0?"
Right, like none.
Because we're all individualized. We're all individuals, and we have all these different hormonal balances. And it's not a problem because we're a human society, and when we have specialized needs, we can turn to experts, and that's what you need. And that's why I'm giving you a general answer to your question. It's obvious that you are not linked up with someone who understands the 1,000 moving parts in your Corvair van engine. Oh, maybe you weren't asking about your Corvair van engine. Maybe you were asking about menopause, but there's more moving parts there. There's a greater complexity there than there is in my Corvair fan engine.
It's
So
a
here's
great
your job.
analogy.
It's the same job. I understand that women have had to reach out and learn a lot themselves because it's not that easy in this primitive time. Oh my God, we're like back in the cave years as far as knowledge and experience around treating women in menopause. That's not so for other medical specialties. There's great genius and great standard of care and great guidelines in neurology and orthopedic surgery and internal medicine, and you name it. These people are highly educated and highly trained and board certified, and that means something. You got a board.
It means a lot.
But there is no board certification in treating women in menopause. There needs to be in our group, our menopause method group, and our IOMIM, our Institute of Bioidentical Medicine. We care a lot about this, and this is one of our missions, is to get that level of training. We already offer that level of training and define standard of care. We've already done that and get people up, tooled up. But your job is you don't have to think about these details. You can't. You're not going to be able to sort them out. But you do need someone who's run into your situation many times and is trained in how to deal with it. You got some kind of imbalance going on. You can't just throw the word progesterone out there or the progesterone dose out there and think this is going to be the answer to the whole story. Obviously, it isn't. And you're probably running more estrogen than your body really can stay without a period, without bleeding, because that estrogen lining is being formed by the estrogen. I mean, that endometrial lining is being formed by the estrogen. So you don't have the proper balance, the proper amount. There's no sin in bleeding. There's no sin in bleeding. There's women, they're rare. It's rare, but sometimes we need robust estrogen levels to save a brain.
Yes.
It's rare, but because most women who are having cognitive challenge, they're managed by non-youthful levels of estrogen replenishing. We know the numbers, we know the ranges, we know what it takes. And we know when it goes higher, when you're using more robust estrogen levels and you're going to form an endometrial lining if you do. And sooner or later, you're going to bleed if you do. That's not the crime. That's not a problem. Now, are we on the lookout for endometrial cancer? Do I think estrogen causes endometrial cancer? I do not. I think cancer is a very complex thing.
Yeah.
I'm not worried about bleeding. And bottom line, in good menopause method, when a woman bleeds, and we don't think she should be, or she hasn't had a period for many years and all of a sudden she's bleeding again, you can do the right thing to make sure that bleeding isn't a rare endometrial cancer. You can go to a gynecologist, almost any gynecologist. They've got the tools in their office. They've got transvaginal ultrasound. They can look inside your uterus. They can see if there's something suspicious in there. They can do a DNC, remove suspicious things. And we do that routinely. If we're getting an unexpected bleed, there comes a point, if it's not obvious from the hormones, that we'll send a woman to our favorite gynecologist. And they're all over the place. These are highly trained and experienced healthcare providers. I know some of you are concerned because they have MD after their name or DO after their name, or sometimes their bedside manner isn't as lovely as, but you're not looking for a friend. You're looking for an expert who knows uterine bleeding like eating your breakfast. Gynecologists know what uterine bleeding is, and they know when they're concerned about it, and they know what to do about it.
Right.
But uterine bleeding itself is a predictable thing if you get enough estrogen. It's only uterine bleeding that when we get concerned about it, you do the investigating, and that's what I want to lead you towards. Now, you've got some kind of hormonal balance going on. I suspect you got more estrogen, but I don't know your dosages. I don't know what you're taking. I don't know what you're applying. And so, but something's going on there.
Right. Yeah, she's at 400 milligrams every 12 hours of progesterone. Her estradiol is 80.
That's an issue. That's a heck of a lot more progesterone. Doesn't mean it's wrong, but our women average out probably somewhere between 75 and 150 milligrams of oral progesterone is all they need.
Right.
But I'm not faulting her for taking that progesterone, but the answer is not in the progesterone. But when I see hormonal balance, when I see nature being exceeded, and at 400 milligrams twice a day, that's a heck of a lot more than your body ever saw. And progesterone can facilitate the action of estrogen and estrogen receptor sites.
There you go. Yeah.
So the thing that matters is we don't do tremendously robust levels of hormones. In the world of treating with hormones, we don't like to choose non-human levels, invented levels. We'll use it therapeutically occasionally, but we like to do what the human design is. And 800 milligrams of progesterone is not the human design. Right. And so when you do things like give these powerful biochemicals in excessive amounts, you're going to throw the balance off in some way. So we start from ground zero with you. We stop your hormones for a while. It would be one approach. We let the bleeding subside and end. Maybe we send you right away for a transvaginal ultrasound. We have a 12-page questionnaire that you fill out online. We learn a lot about you. So these final decisions are made based on your individual situation. Your individual situation might be, before we proceed, I'd like to get a transvaginal ultrasound. I'd like your gynecologist to weigh in on this. Oh yeah, everyone wants to rush to their gynecologist because can't think of anything better to do in a day than let me have a gynecologist appointment.
Well, you can always see a good dentist, I suppose. That's equally as fun.
I know. Do I like going to my dentist? No. N-O. I've got a dentist appointment coming up.
Ditto.
Do I have deep gratitude for my dentist and my hygienist? Oh, God, yeah. They've saved my teeth. And I get cleaning 3 times a year minimal. Deep cleaning. Do I love going to that visit? No. Am I deeply grateful? Yeah. Do you love going to your gynecologist? No. Do I love going to my gastroenterologist and getting a colonoscopy?
Every chance I get, I go.
Right.
Not.
Sign me up. But we do what we need to do.
That's right.
And sometimes it's a little bit inconvenient, right?
Just a little. But you know what? Again, you've answered that question, I think, really, really well. And I believe there's a thank you, Dr. David Rosensweet. My favorite 3 words, Dr. David Rosensweet. And I think it's from that questionnaire. I do. So,
There's one other thing I want to say about this.
okay.
Learning your levels is just not that helpful so often. I mean, how much estrogen did you take, and when did you take it, and when was your blood drawn? It's blood tests of female hormones are useful somewhat in a woman who's not taking hormones. But when a woman is taking hormones, you want to get an idea what's going on. You do the 24-hour urine hormone test. Did I say the 24-hour urine hormone test? And I didn't say anything else. I didn't say any urinary pee on filter paper stuff. No, I did not. No, I did not. I said the 24-hour urine hormone test. When a woman is taking hormones, it's great. The 24-hour urine hormone test is fabulous. So, but I don't know when did you take your last estrogen dose? What was that dose? When did you have your blood drawn? This stuff doesn't hang out in your blood forever. This is not a natural repository for your estrogen. You got to really know what you're doing and have had a lot of experience and get the timing right on your blood draw. So I don't know what your hormone levels are, but I can tell you this: you got overstimulation of the uterine lining by usually excessive estrogen, or you got something in there that needs to be seen and needs to be seen by a gynecologist. And the bottom line is, when you got a tricky situation, there's people who know about it.
Right.
And your job becomes this, and it's not an easy job. Find them. They're around. There's a lot of them. Find them and get thee to them, and then know how to sort this out, including the hormones.
Yes. Yes. Oh, do the doctor shopping. I've done it. It was worth it. It took forever, but it didn't matter because your life will matter to you just as much if it's 17 years later as it was for me, as it did 17 years ago. 17 years ago now to me is like I was a different person, but my life sure matters to me today, and I'm very grateful for it. And certainly my hormones. This is an interesting question that arose actually. Let me switch papers. This one has to do with perimenopause, which seems to be very, very confusing as well to many women, as is menopause. And this thing called postmenopause, which personally I don't quite believe in, but
There is
nevertheless,
no such thing.
right? Yeah, exactly. I don't know what it means. So she says when treating a woman in menopause who gets her period some months, or perimenopause who gets her period some months but does not on others, how do you approach this? Is there an argument for supporting the cycle, these cases, and doing estrogen in the first half and then progesterone in the second? Is there a way to like regulate the cycle so that um there's less, for lack of better word, like Mishigas that goes on with men until actual menopause happens. The wackiness of no periods, no periods, testing, no testing. Well,
Well, here's my question to you.
okay.
What does the word Mishigas mean?
No clue. It was something I learned as a young kid. It works. It sounds good. And to me, it means like craziness and verklempt. That word. That explains it, right?
It's a Yiddish word for chaos and
That's
craziness
right.
and nuttiness.
Yeah.
And who knows what's going on?
Right. It's chaos.
Yeah. So here's the thing about the perimenopause: to know what's going on, just to begin with, and download our book, Happy Healthy Hormones. And we describe this. It's a very unusual time in women. For one thing, there was no perimenopause for most of human history. Women didn't live that long, and men did live shorter lives than women did. And what happens is your ovaries stop being able to produce the youthful levels of hormones. There's 4 of them. estrogens, testosterone, progesterone, and DHEA, your ovaries stop having the power to put out that amount of hormones, and they don't. And your brain reads that. If I may be metaphorical, the brain goes, yikes, we're losing the ability to conduct a normal menstrual cycle and have babies and stuff. And the primitive, primal, original genetics says that's an important thing to do. So the brain puts out a fight or flight response to try and revive those ovaries. And it gives out this jolt of ovary stimulating hormones, trying to wake them up. Wait, don't stop producing these ovarian hormones. We want these. And the ovary, which is not producing as much, it receives that jolt of stimulating hormones from the pituitary gland, and it responds. It puts out a whole bunch of hormones. It's a jolt. In fact, it can put out more hormones in a day than a woman did when 20 years earlier, because there's a jolt of stimulating hormones, but it can't keep it up.
Right.
So those levels fall really low again. And what you see, if this makes sense to you, in a woman's normal cycle, this is day 1, first day she bleeds. This is tracking the estrogen in a cycle. As day 12 approaches, she's getting a certain peak level of estrogen, nice and smooth. And then if she ovulates in there or not. And then the estrogen levels drop, and then they continue at these nice, smooth, beautiful curve that we illustrate in the book. Very regular. The orchestration is just staggering how elegant it is. Well, in the perimenopause, it ain't that smooth.
Yeah,
Because a woman's putting out lower levels of estrogen. The pituitary goes, don't give up the ghost, and it puts out a jolt of stimulating hormones. Bam! They get a super high peak, but then the ovary can't keep it up, so they get a trough, peak, very irregular, and that is the rodeo ride that a woman in the perimenopause. My interpretation of the original design of this erraticness and this drive you nutballishness is it's
no, don't freeze now.
the rest of your life going here. And that's the purpose of it. That's my interpretation of the purpose. Don't quote me on it. I don't think this is medical canon. The one thing about the perimenopause is it is the most challenging time to get these hormones regulated. No doubt. It's a rodeo ride to figure this one out. So don't feel uncomfortable about yourself that it's a little tricky. It's the trickiest time of all
Right.
to get it right.
Do you test?
However, it doesn't get better from my perspective for a woman to start these hormones in the perimenopause or earlier. So if you're able to find your way to someone who knows what they're doing, you can't do better than this. Now, we won't turn down an 80-year-old, providing we go through the proper process to evaluate her heart and stuff and her coagulation and stuff. So anytime that you're able to come upon the hormones and replenish them, good on you. But it doesn't get better than the perimenopause. Now, here's the strategy we use in the perimenopause. Since your general hormone levels are lower, we like to give you general replenishing to bring them up so it's not such an erratic ride. We don't try and restore youthful levels. We just take the fall and bring it up to reasonableness, and that evens things out in many women. It's not going to keep your periods going. In order to keep your periods going, you're going to need 3 to 8 times the upper limit of normal of a 20 to 29-year-old level to do that. That's not physiologic. That's 3 to 8 times the upper limit of normal to keep that period going. So you don't have to worry. You replenish your hormones decently, and you're going to be fine. Now, it still makes it a bit of a rodeo ride. And, I had something on the tip of my tongue there that's important. I've done very, very careful, highly designed, trying to replicate the cycles Like some people say, only give a woman in the perimenopause progesterone in the second half of the cycle because that's how nature does it. And I was because I love spreadsheets and because I love math, I went so far as to map out variable dosing to a young woman who was occasionally having cycling, replicating the cycling of a young woman. Variable dosing throughout the cycle to replicate. And I did this with all my patients, and I've had the great privilege of having a demographic of women who really care about this. They really care about their health. They're very intelligent. Every single patient of mine, when I originally did this experiment in the early 2000s, giving them a spreadsheet of variable dosing, they all did it gladly because they just did it because they care about it that much. They wanted to get it right, and they thought it was fun. And then every year I do an annual visit on, and every one of these patients that I did it on, I said, what in their annual consultation, I'd say, well, how'd all that go for you? And she said, well, to tell you the truth, I went back to the steady dosing because I didn't really like the variable dosing. It wasn't that I had that much trouble doing it. I just didn't feel as good. Woman after woman after woman on her own had gone back to what she was used to, which was steady daily dosing. Even though cycling makes sense. Then Dr. Jonathan Wright offered that we should test these women that I'm doing these fancy cycles on just to see what they're getting. And so we tested them on day 12. I'm sorry, on day 7, day 12, and day 21 because we were cycling. And what did we find out? That on day 7, they had their lowest levels of estrogens. Makes sense. On day 12, when they should have their highest levels of estrogen, they didn't. Their highest levels of estrogen occurred on day 21. So when you're applying hormones from the outside, no matter how you're taking them, you're not copying nature. This is not doing what the ovary does. But the biggest thing is the women themselves had abandoned that. So I know there's advocates of keeping the period going, but that's a whole other discussion. I'm not going to go there.
Right.
But our objective in the perimenopause is restore some decency to the hormone levels so that a woman's not getting hot flashes and she's sleeping better. And if need be, that we give her additional testosterone. And that'll usually even out most women. It's a rodeo time of life. This is not the easiest time of life. There's a lot of things that intersect there. It's called the change of life. Gee, where in the heck did it get that name?
Right.
And it wasn't because you lost your periods. It was because a lot of factors. You're leaving a certain type of youthfulness in householding and raising kids. And then what happens? The S hits the F from
Back at you, Dr. Rosensweet.
on every level of being. On every level of being. So there's more moving parts, including emotions in the mind. Hang on a second. I'm going to go a little extra time because I got such a late start, so I have to notify someone.
Thank you. It's a good point you make, Kathy. Yeah, that maybe we should define postmenopause as the period of time during which a menopausal woman is being treated by a well-educated hormone provider.
There you go.
Perfect.
That's a good definition. However, I don't like the word postmenopausal because it implies that the menopause is over, and it ain't.
Yeah.
It's never over. Your hormones start declining when you're 22 maximum, and they never stop declining, and that's not good. So,
No.
but I like your approach, Kathy.
Yeah, right.
So that's our approach to the perimenopause.
Yeah,
but again, it always is going to come down to the same thing. You've got to work in partnership with the individual woman because I can come up with all kinds of theories, but there's 100 exceptions. So we wind up individualizing. We learn about the individual woman, and when I've learned everything that I can about her, we come up with ideas. Oh, maybe we should approach your perimenopause like this. And we do. So it's individualization. It's the perimenopause. It calls for a degree of skill and practice that is different than a woman who's 5 years without a period. She's steady as she goes. And geez, if she doesn't start taking hormones for 5 years into menopause, well, I'd much rather be, no, I shouldn't say that. I'll treat a woman at any age, replenish the hormones. But a woman who's 5 years without a period, this is a very steady situation. This is not something that you're oscillating like crazy.
Right.
It's a much easier program to design and implement.
Cool. Well, thank you.
I'm going to take one more question, and I'm going to run a little over today because I was so late in arriving today.
You made me nervous. All right. So this is a good one, I think, that you can answer quickly. Can I take testosterone and progesterone without taking estrogen? I know it's individual, but
no, I would advise highly against that.
okay.
You're low in estrogen, testosterone, and progesterone and DHEA if you're menopausal. And estrogen is a beautiful, amazing hormone that is of no less stature than any other biochemical in your body. In fact, it is so important that you don't want to be leaving estrogen out. I can't, in all the women we've ever treated in menopause, we have never left out estrogen ever.
Yeah, I've not heard of it myself.
For very, very good reasons, you know. So I don't understand why someone would want to leave out estrogen. I could make a guess of why you think you might want to leave out estrogen, but that's wrong. So read the book by Carolyn's father's dear friend that Carolyn hung out at his house by Avram Blooming. He's an oncologist that specializes in breast cancer. And if someone has fear of estrogen, they need to read the book called Estrogen Matters.
It's a good book written by a brilliant man.
Absolutely. And it's the Bible on the false information that is thrust upon women in a misogynistic way to damage women is all I can. That's the outcome. I don't know if the intent was that, but that's the outcome. Damaging women.
It did just that.
Misogynistic event because it makes women afraid of estrogen. Huh? Should men be afraid of testosterone? Well, that little bit of that was done with men, but it's the opposite of what's true. Men who are treated with testosterone are less risk for prostate cancer than men who are untreated. And women who are treated with estrogen are at less risk for breast cancer, heart attack, and stroke than women who receive no treatment.
Right.
That's medical science. So I'm going to take a deep breath and say sayonara for today. And what a pleasure to be with you, Carolyn. And I will be on Thursday. I will be on time on Thursday.
Thank you, because I don't like to worry. So I seem to do it 24/7 just anyway. I'm born like that. You know, ladies, thank you so much for coming up. Dear Dr. Rosensweet, always a pleasure. Always, always a pleasure. Have a really great day. And we'll get to these questions. We got to some of them, and we'll get to some more. And we'll just do it all over again on Thursday.
Sounds good. Bye, everybody.
Bye.